Friends, welcome back to my YouTube channel Medical Classes by Dr. Srinidhi Kumar Acharya. Please don't forget to subscribe my channel and also please give your valuable comments. So in the last three classes we have seen about the ataxia and how to differentiate it and the role of the cerebellum in maintaining all these things. Now today we will look into some other clinical aspects related to ataxia, how we will approach as a whole, okay, when you are getting a patient. Now there are some spelling mistakes. Okay, mode of onset, progression, and focal or symmetrical. Now, ataxia may be understood in different ways. Now, one of the thing is you have to see whether this particular ataxia is focal or whether it is generalized, whether it's acute in onset, whether it's gradual in onset, whether it's intermittent or whether it's episodic. So, these type of approach has to be done to understand the ataxia very well. Now, focal, that means it may be sometime one-sided, or sometime it is maybe symmetrical, sometime it is bilateral. That means ataxia is only there in the one side, only one side he is falling, or on both sides he is falling. Okay, so sometimes it is a focal, only in the upper limb, not in the lower limbs. Only in the upper limbs there is some ataxia, or in the lower limbs there is ataxia is there, but in the trunk there is no ataxia. So such things can occur. Okay, sometimes it occurs very fastly also, ataxia. For example, within hours we know that intoxication, after intake of the alcohol there will be ataxia, isn't it? So if after intake of alcohol, if the patient try to walk, he will have ataxia, and this is very acute actually. Okay, alcohol induced. Sometimes approach may be there because of vascular. Okay, some of the vascular problems may also lead to this set of problem, that is posterior cerebral artery problems, middle cerebral artery problems, subdural hematoma, infarction, thrombus, etc., which is occurring in these arteries, or sudden cutoff of the vasculature, okay, sudden cutoff of the blood supply. That may also lead to some of these time ataxias. Intoxication, as I told earlier, alcohol, lithium, phenytoin, and barbiturates. These are the most common things which cause ataxia. Phenytoin is one of the most common drug. Okay, after intake of phenytoin, there will be ataxia. Barbiturates also. Next, post-infectious, after infection of the cerebellum area or any infection happening in the sensory tracts area or in the vestibular area, so there may be ataxia. So hyponatremia is one of the cause from the metabolic point of view, acute metabolic disorder which can cause ataxia. Most of the time hyponatremia, less sodium, so that can cause ataxia. So like this, one by one we will see the different approach. So these are some of the focal and acute causes we have seen. Now subacute causes, that means little slow. For example, intoxication. The intoxication like mercury intoxication, solvents, etc. Okay, so they can cause intoxication but little slow, subacute. Nutritional causes, for example, B12 deficiency, B1 deficiency, vitamin E deficiency. Okay, so they can also cause ataxia. We will see later. They can also, they are all the major causes of ataxia or imbalance. Etc. Then vitamin E, vitamin B12, okay, even vitamin B1 deficiency. Now infection like HIVs, then demyelinating disorders, they cause subacute. For example, multiple sclerosis. Multiple sclerosis is one of the example of subacute ataxia. Here there is a demyelination going on, and because of which there will be ataxia. Then sometimes neoplasm, any tumor pathology, benign tumors, or which is pressing the cerebellum, particular areas of the cerebellum like glioma or sometimes metastasis, it may also cause the ataxia. Focal and acute, sometimes localized ataxia will be there, but it is very acute. This can happen in intoxication, drugs, acute viral infections, post-infectious syndromes, etc. Subacute infection, which is happening in days to weeks. Okay, this is quite common in demyelination disorders like usually multiple sclerosis, alcohol-induced vitamin deficiencies, etc. B6 deficiency, I think, alcohol-induced, B1 and B5, something like B1, either it is B1, B5 or B6 deficiency, which is common in alcoholic syndrome, alcoholism. Anyway, now some of the time ataxia is chronic. Okay, what are the chronic causes of ataxia? For example, autoimmune causes, pre-neoplastic syndromes. For example, a patient with breast cancer, ovarian cancer, etc. So they are more prone to develop ataxia. So that is because of some of these autoimmune causes. Gluten hypersensitivity. okay, anti-GAD antibody, etc. In hypothyroidism, there may be ataxia, chronic ataxia. Some of the infections like syphilis, they may even cause the chronic ataxia. Tapes dorsalis, posterolateral columns, so we get Robinson's pupil, etc. I think you may be knowing it. Then congenital lesions, they also cause the ataxia slowly. Similarly, inherited ataxias, again they are slow. Friedreich's ataxias and ataxia, telangiectasia. So they are all gradually progressive ataxias. Okay, there are some metabolic causes as we have explained earlier. So like this, ataxia may be chronic, focal, etc. Now talk about progressive ataxias. So classification of the Greenfield and Harding will be there. So now the spinocerebral ataxias, okay, spinocerebral, as the name suggests, spinal sensory cords, tracts which are going upwards, ascending tracts, and the cerebellar. So there is involvement of the both. There is involvement of the spinocerebellar, spinal ascending spinal tracts like proprioceptus, dorsal root columns, etc. And also cerebellum is affected. Okay. So in such conditions, spinocerebellar ataxias, we will have the Romberg sign positive. Okay, Romberg sign positive suggests of sensory ataxia. Okay, there will be also sensory loss. Yes, because sensory tracts are affected. Diminished tendon reflexes, because again, it is affected, movements are affected. Then Babinski's sign will be positive. So this is seen in case of spinocerebellar ataxia. Along with that, so these are the problems because of the spine, the sensory nerves. Cerebellum is important in maintaining the balance. Cerebellum is maintaining the speech. Cerebellum is important in maintaining the tone. Okay, so these problems will be also there. So if there is a mixing of these two, then we will call it as a spinocerebellar ataxia. Okay, now only pure cerebellar ataxia means there is only ataxia without any other neurological signs. Okay, sensory roots are not affected, and other vestibular nucleus is not affected. Only cerebellar, pure, means only ataxia will be there without any other afflictions. Okay, of course, the functions of the cerebellum will be get affected. We know that. What are the functions of cerebellum? Now, complicated cerebellar ataxia is there. So, with a variety of pyramidal, extrapyramidal, retinal, optic nerve, oculomotor, auditory, peripheral nerve, and cerebrocortical accompanying symptoms, everything will be there. Another type of ataxia is called as static ataxia. Static ataxia means it is because of the vascular causes or some of the congenital anomalies. This will be there. Reversible ataxia. So this is some of the time infections. Some of the infections cause the ataxia, but once the infection is over, the repair is taken place, then the ataxia disappears. Reversible. Okay, even in case of thyroid, after starting of anti-thyroid drugs, then it will be, that means after starting the drug for thyroid hypothyroidism, it will be okay. Drugs and toxins, etc. Once you remove the drugs, once you withdraw the drugs and toxins, the ataxia will be okay. That is called as a reversible ataxia. Episodic ataxia, which comes in episodes. Usually this is in case of metabolic problems. Most common is hyponatremia, sodium depletion. Okay, so even some of the potassium channel defects and the sodium channel defects, they may cause the episodic ataxias. Another is focal symmetric ataxia. Focal symmetric ataxia. So focal, symmetric. Okay, both the sides the upper limbs are gone. Both the sides the trunk is gone. That means right and left, like that. So now cerebellar symptoms on the same side of the lesion or there may be sometimes bilateral symptoms also. So similarly we have got symmetric ataxia because of intoxication, nutritional, post-infectious, hypothyroid, autoimmune causes. Then now come to the localization of the lesion. Cerebellar hemispheric syndrome. Cerebellum we are talking in that hemispheres. So in case of hemisphere problem of the cerebellum, ipsilateral head and body is affected, and cerebral signs will be there in the ipsilateral side. Okay, so cause may be infarct, neoplasm, abscess, demyelination, etc. Rostral vermis syndrome, that is gait and that is vermis get affected. So that gait and a truncal ataxia will be there. Most commonly seen in alcoholism, B1 deficiency, etc. Now caudal vermis syndrome, that is the tapering portion, the last portion of the the vermis is get affected. Suppose caudal I think upper portion, not the last portion, upper portion, caudal vermis syndrome, you will have disequilibrium, trunk ataxia, as in case of medulloblastoma, etc. Then pancerebellar syndrome, everything is affected. Vermis is affected, upper portion, lower portion, middle portion, cerebellum, both hemispheres, everything is affected. Pancerebellar syndrome. So we have got the bilateral signs. This is usually caused by the toxins, metabolic problems, infections, autoimmune causes, and inherited causes. Cerebral peduncles are affected sometime. Okay, so in that time again the dramatic cerebellar symptoms will be there. There are some acquired ataxias. First, rule out the structural causes. If you go for one imaging study like MRI, you can rule out these structural causes. Okay, so congenital vascular anomalies, posterior fossa tumors, demyelinating disorders, hypoxic encephalopathy, vascular causes will be there. So which are some of the causes for the acquired ataxia. Similarly, now important is inherited ataxia. In children this is very common. Autosomal dominant disorders are there which causes the ataxia. Autosomal recessive disorders are there which causes ataxia, inherited ataxias. Mitochondrial inheritance will be there, X-linked recessive will be there, X-linked dominant will be there. Okay, now autosomal dominant type of ataxia, that means ataxia which is occurring because of autosomal dominant condition, the spinocerebellar ataxia, type 1 to 31 types are there. Okay, episodic ataxia like 1 to 7 types are there, and rubro-pallidoluysian atrophy, like that, different disorders are there. Even in the spinocerebellar ataxia may be because of the inherited causes. Now actually what is happening is frexcitin, one particular important protein is there which is very important for the formation of the myelination. Okay, so when this frexcitin is absent because of some of the genetic defects, when this frexcitin protein is not formed, then the myelination will not be there and the sensations cannot be carried upward, isn't it? Because these are expressways, highly myelinated tracts. Sensory tracts means they are highly myelinated. Now when there is a problem in that particular highly myelinated tracts in the formation of the myelin sheath itself, then sensations are not carried and that causes a problem, and this problem is again inherited. Okay, so such many things are there. Phenomena is called as anticipation and penetrance, that's genetics. The most common defect is a CAG repeat expansion defect. Okay, SCA5 Lincoln's ataxia, SCA12 which is commonly seen in Agrawal community, SCA10 which is commonly seen in pentanucleotide repeat expansion. So like the different types of spinocerebellar ataxia, cerebellar ataxias are also inherited in nature. One of the most common example is Friedreich's ataxia. Okay, so autosomal recessive ataxias, most commonly we will have Friedreich's ataxia, ataxia telangiectasia, ataxia with isolated vitamin E deficiency, A beta lipoproteinemia. Okay, because fat soluble vitamin is vitamin E. Vitamin E is also very important for the formation of this myelin sheath and all. So that may also cause the problem. Yeah, A beta lipoproteinemia. In A beta lipoproteinemia, we'll have the problem with the fat absorption, fat malabsorption will be there. So fat soluble vitamins are not get absorbed. That leads to the problem. Some of the enzyme deficiencies may also cause ataxia. For example, Maple syrup syndrome, urea cycle defects, then adenoleukodystrophies, organic acidurias. Then we will have episodic ataxias in all these conditions. Okay, so this is some of the clues how we have to approach to ataxia clinically. Thank you very much.